Welcome to the Post-COVID-19 podcast brought to you by HITAP, Building a Stronger Healthcare System. My name is Madison. This episode, as well as the whole series, is funded by the Ministry of Public Health, Thailand. Thank you very much for listening in. Today, we have a very special interview with Professor Matthew Eckelman from Northeastern University College of Engineering and Yale School of Public Health. We will be discussing greenhouse gas mitigation strategies in the healthcare sector, and specifically within the context of low and middle income countries. We talk about some of the most effective strategies, how mitigation can be aligned with healthcare access and quality, and what steps can be taken to ensure research is actionable. So thank you, Professor Eckelman, for being here today. Do you mind introducing yourself to everyone?
Hello, my name's Matt Eckelman. I'm a professor in environmental engineering at Northeastern University in Boston, Massachusetts, in the United States. And I've been working in healthcare emissions modeling and environmental assessment for about 10 years, trying to quantify the emissions associated with healthcare, both at a systems level and also in specific practice.
Great. Okay. Thank you so much for taking the time. I know everyone at HITAP and then also our colleagues at Chulo and Corin have been really appreciative of your time, both with helping us with our project, and we're excited to learn more in general about your work and how we can take this forward in Thailand and across low and middle income countries. So maybe to first start off, to provide context, can you walk through some of healthcare's biggest contributors to GHG emissions, or I should say greenhouse gas emissions, at least in terms of what we've shown so far, mostly that research coming out of high income countries?
Sure, happy to. So greenhouse gas emissions are quantified into three general groups, which we call scopes. Scope 1 corresponds to direct emissions from a healthcare facility. That's, for example, emissions from combusting fuel in a boiler in the basement of the facility. Scope 2 is associated with emissions from buying energy. So most hospitals use electricity, and in order to generate that electricity, if it's a fossil fuel plant, for example, there's some emissions associated with combustion of those fuels. And so those get counted as scope 2. And then the third and last scope covers everything else, what we call value chain emissions. So that could be emissions upstream from manufacturing goods that hospitals use, like drugs and medical supplies and equipment. And it can also be emissions associated with getting people to the hospital, with transportation, and with even home care. So anything that happens off-site, we classify that as scope 3. And what we've learned in studies of various countries around the world, and probably a few dozen countries have been analyzed at this point, is that scope 3 emissions are the largest group. In the United States, it's about 80% of the total. And in other countries, it's maybe a little bit less, but in that neighborhood. So this is surprising to a lot of people, because when we think about hospital emissions or healthcare facility emissions, we focus on what we can see. We focus on energy use. We focus on the fuels that are in front of us in the facility, and we don't see those emissions that happen upstream or downstream. So it's really important to know that those, in fact, are the largest. And within scope 3, the categories that make a big difference are food. Many healthcare facilities are also provide food for their patients and visitors and staff. Another big category is drugs and pharmaceuticals, and also other chemicals like cleaning supplies. And then the third big category is medical devices and supplies. So those are both the kind of one-time consumables like cotton and gauze, or even the durable instruments, like surgical instruments. So there's lots and lots of different categories out there. Those are the big ones. And knowing what's important, knowing what the largest categories are, helps us prioritize our efforts in reducing emissions.
Okay, great. So looking at those main emitters, what are some of the mitigation strategies that can be implemented in hospitals or other healthcare facilities in general, maybe specifically in scope 3, to help kind of reduce those total emissions?
All right, so I'm happy to talk about scope 3, but just because scopes 1 and 2 are smaller relatively, it doesn't mean they're less important to go after. And in some ways, they're a good starting point because most facilities have good tools in place to track those emissions and to mitigate them. So in general, when healthcare facilities or healthcare systems get started in their decarbonization planning and strategy, they usually focus on scopes 1 and 2. So that means upgrading their heating system. Maybe there's an opportunity to avoid fossil fuel generation and use a heat pump, an air source heat pump or a ground source heat pump. So that helps with scope 1 emissions. On scope 2, anything related to energy efficiency helps. One of the most common things that people start with is changing out and upgrading the lighting system, going to more efficient types of bulbs and ballasts. So for example, moving to LEDs in the hospital. But even outside of lighting, any kind of electrical piece of equipment, even computers and fans and motors and so on, all of those things, keeping them in good working order and upgrading them when available to high efficiency models can help save energy. So you get some cost savings and also reduce emissions. The kind of second part of the scope 2 side is just to reduce demand for energy in the first place. And you can do this by making the building more efficient thermally. So if you're in a place where you need a lot of heating, then insulating your building, upgrading your windows, making sure they're sealed, trying to reduce leaks, all of that can really help reduce energy use, again, reduce costs, and also reduce these emissions associated with energy use. Now, on the scope 3 side, there are also some easy wins. I think the biggest category is trying to reduce waste. So you remember those 3 big categories: food, drugs, and medical supplies. In a lot of facilities, and I'm based here in the United States, but in facilities I visited here and elsewhere in the world, there's a lot of waste associated with healthcare. Some of that is necessary, of course, but there's many instances where we're throwing things away that could be reused. Sometimes we throw things away that weren't used at all, right? But we had to open the package and we didn't happen to use that instrument or that supply, and so we just throw it away. So we've designed our systems in many ways to be wasteful systems, and rethinking the way that we procure items, buying things in the sizes that we need can help reduce waste in material terms. And that means we don't have to manufacture as much material and we can save emissions in that way. Yeah, same with food, right? Reducing food waste, apportioning things correctly, composting waste, or somehow managing food waste in a low carbon way. That can also really help.
Yeah, I think maybe just anecdotally, I think I've been on the side of healthcare in the US, being a healthcare provider, and the amount of policies where you have to throw something away because you open the package just the tiniest amount, and the amount of waste or the amount of blankets that I've thrown away because they're contaminated, even though no one touched them, is quite ridiculous. But so I think you may have already kind of answered some of this in that question. But in terms of how accessible these mitigation strategies are and what the easiest are, maybe you've already said that scope 1 are maybe a good starting point. Maybe if you could provide a guess, or maybe you have this information already, what do you think are some of the most cost-effective or the most accessible in terms of how cheap they are, or how much time or effort it's going to take to implement these?
Yeah, we do have some good numbers on that. In general, anytime you have to buy something new equipment, or upgrade like new insulation for your building, of course that costs money. And in many low and middle income countries, access to capital is a major challenge. That's true everywhere, even in high income countries. So it'll take some time to realize those economic savings. And if you think of this metric, dollars spent per unit of carbon reduced, right? We want that number to be as low as possible, right? So that we're being as effective as we can with the money that we have to invest. But there's a whole group of things we can do that basically doesn't cost us anything. For example, anything to do with reducing waste, in terms of buying portions or buying sizes that are appropriate. Let's say I'm buying 100 ml vial of a certain drug, when most of the time I'm only using about 3 to 4 ml for a patient. So that we see this pretty frequently. And if I could buy, let's say, a 10 ml vial, or maybe just to be safe, a 20 ml vial, I would save 80 to 90% of the cost of the drug, right? And I would avoid those associated emissions too. So there are a lot of opportunities that are win-win opportunities. We save money, we reduce waste, and we reduce emissions. And I think those are the easiest places to start. It's easy to convince administrators that this is a good idea because, hey, you're going to reduce costs, and it's good for the bottom line of the hospital.
Okay, no, that's great. I think my next question is maybe switching gears, talking about how these mitigation strategies can be aligned with access to healthcare. And maybe I'll use an example, Thailand. So there's a lot of what we call health promoting hospitals and their primary healthcare facilities. And I don't know what year, so that they used to be called something different, at least the English translation was different. And several years ago, I don't know how long ago, the Ministry of Public Health changed the name of these facilities with kind of the hope that this would be perhaps a self-fulfilling prophecy. If they were named hospitals at some point in time, the hope is that these will be kind of expanded out into larger facilities to increase access, especially in rural areas where this is the kind of primary point of access to care for a lot of rural areas. These facilities it's funny because when I first went to one, I didn't realize that I wouldn't necessarily label them as a hospital. They're more a clinic. They wouldn't even necessarily qualify as an urgent care. There's only several staff members. They're only open certain times of the day, and you can only see a few patients. So they're fairly small. So in this example, one of the hopes is that these will be expanded. And I assume a lot of these facilities are in very flood-prone areas. So they also need to kind of consider how these facilities will be climate resistant, how these will be expanded, but also considering future, ability for these healthcare facilities to exist in, a climate change world. So with those two kind of agendas, how do you see GHG mitigation being centered in this? Or perhaps what do you think can be done to ensure that there's political will to fund GHG mitigation when you have limited funds or limited resources when you're increasing access to?
All right, great question. Yeah, so for me and for all of the colleagues that I work with in this space, the goal is always to increase healthcare access and quality. We're looking at greenhouse gas emissions as a consequence of the healthcare system, but we don't want to make any kind of recommendations that would reduce access or quality of care. So I think it's important to center all the discussion around the overall goal here. When we view countries against each other, compare them with each other in terms of their greenhouse gas emissions, a very common thing to do is to look per capita, and of course you get very different answers, and some of that is that there are different levels of access and quality in high-income nations versus low and middle-income nations. Of course, there's just simply more economic resources to make healthcare available. So we have to be really careful in making comparisons and trying to learn from one another across countries and also within the same country, um, and make sure that we're accounting for differences in situations and different orientations of different facilities. So with that kind of caveat, I would say that there are also in this situation lots of win-win opportunities to have buildings that provide healthcare clinics and hospitals and nursing homes and so on, all those kinds of facilities be both climate resilient, so be able to withstand shocks and temperature increases and floods and high winds, but also to be more environmentally sustainable. And for these purposes, to say low carbon as a proxy for that. So for example, having on-site renewables in a rural area is a very common kind of approach. It's really expensive to bring electricity sometimes to a remote healthcare facility. But if they have their own power, that's from solar panels, for example, or from a geothermal system, then they can power themselves. So it's cheaper in many cases. It's more resilient because they can serve as a center for the community if the power does go out or if there's a big extreme event or natural hazard, and then it's also more sustainable, right? Because you're using renewables rather than relying on electricity that might come from fossil power plants. So we always try to find these opportunities, and they exist. Anytime you have the ability to do things locally, to provide your own resources and make the most of the resources that you have. Another example I see a lot is around how devices are managed. In the United States, where I am, there's been a tendency to move to single-use devices. So we open things up, we use them once. Sometimes there's contamination, but that's not always the case, and then they get thrown away. But those same devices, if you go to other parts of the world, can be made in using very durable materials, and they can be reused. Obviously cleaned and reprocessed, sterilized if necessary, but then reused. And when COVID started off here in the US, all of these facilities that were relying on single-use devices, and especially for personal protective equipment, we ran out, and it was a major, major health disaster, actually, in many places. Whereas places around the world, facilities that had the ability to reprocess their own equipment, they didn't rely on these supply chains that broke down. They could be more resilient in their approach to dealing with this pandemic, and also it's a more sustainable practice. You're using less material overall. So I think there are a lot of opportunities like that where you have both better resilience, better sustainability. I work in civil engineering, so codifying that, making sure that your healthcare facilities are anticipating what heat and what flooding and what kind of precipitation we expect, not just today, not kind of historically, but in the future, and building buildings that are appropriate for that future. That's certainly going to be key.
Great. So I kind of maybe have a secondary question on that. In terms of, how the healthcare has changed after COVID, there's been an increase in telemedicine, telehealth services. I'm curious if there has been perhaps like a comparison in how that has changed GHG emissions, because I assume my first thought is that when you're cutting out perhaps transportation, but you may also, I don't know how much more e-waste you're creating when you're moving to a more telehealth heavy healthcare system. I assume most people have personal devices, but on the healthcare facility side, I'm not sure how much expansion there is in terms of what, hardware, what actual like physical things that you need. I'm curious, there's been like a comparison with these changes.
There have been comparisons. It actually is a very complicated question to answer. And it's a question we've had for a long time, basically ever since we invented the telephone for conference calls, and you could be in a different place. You didn't have to be in the office. So there's some special considerations for telemedicine, because if people aren't coming to a hospital facility or a healthcare clinic, for example, there are energy needs in a hospital that are really different than the energy needs in someone's home. So if they're doing a telemedicine call from home, right, their home has its heating system and that's pretty typical, or maybe there's some air conditioning. But if you go to a hospital, hospitals have very high requirements for ventilation. Yeah, so there's a lot of heating and cooling and fans that have to do with appropriate ventilation, and that makes a lot of sense. We're trying to avoid spreading infection in hospitals, so that this is one way to help prevent that. But most homes don't have ventilation requirements. I can speak to here in the United States anyway. If you're in a tall condo building, it's a little different. But if you're in your own smaller home, then yeah, you have your windows, but there's no mechanical ventilation. So you have a lot of savings in that way because you don't have to run those. You're absolutely right. You do get to avoid those emissions from transportation, and that can be important, but typically that's usually like 5 to 10% of the total greenhouse gas emissions. So it's not as large as a lot of people think. Yeah. The biggest advantage, I think, is if you structure your facility for telemedicine from the beginning. Yeah. So instead of building a hospital with 100 beds or 100, rooms, then you can basically downsize the hospital because you can do more visits by telemedicine. And this just means you have less energy use for those fans and ventilation, but you also have less concrete, less steel, like all the physical things that go into the hospital. So you can have some really big savings that way. Yeah, what I see on balance, there's a lot of different people working on this problem. In general, I do see savings from telemedicine, but it's complex, and in some situations, there can be a kind of what we call a rebound, where those savings aren't as high as you might think.
Sorry, just to clarify, when you say savings, are you talking about like monetary or GHG emissions?
Sorry, the GHG emissions.
Okay, I see. Okay. So my next question is about perhaps moving on to like the research side. In terms of ensuring that the research that people are doing, maybe if we're talking to, let's say, a researcher who wants to get into this work, quantifying GHG from the healthcare facilities in their country, what kind of recommendations would you take, or what would you give to ensure that this research actually affects change? Either from your experience, what do you see as being very effective to ensure that there is change, either policy or not, and what has maybe been not as effective?
Sure. I have 3 pieces of advice. First is find collaborators. This is such an interdisciplinary problem, right? We're talking about one of the most complex kind of social technical systems that humans have invented. And especially if you're in a critical care, urgent care kind of facility, the building itself is very complicated. The supply chain for all the stuff that is needed, that's also very complicated. And then the actual delivery of care is highly complicated. And then what happens to all that waste, right? That you have to manage it very carefully. So in my experience, the best, most impactful kind of studies are those done by teams, where you have clinicians paired with administrators, paired with engineers, paired with sometimes even waste management professionals, people. So you can see the whole system and really understand the whole system, and that you can identify what your actual levers are. What is practical to do, and what's really impractical because of different constraints. No one person, I think, can really wrap their head around all the nuances in healthcare greenhouse gas emissions. So that's my number one piece of advice: is find some collaborators who are passionate about this problem, and try to work with them. Number two, I would say, is choose problems that really matter. There are so many items, so many different supplies and services and devices and aspects to healthcare. And you can, of course, focus on anything. So in my research and in my collaborations, especially with clinicians, we try to identify problems that are either really large. So it's like we try to look at the most common supplies and the most common devices or the most common procedures, or they're topics that are have some questions where the community's looking for answers, and they're saying, well, there's this option. I could do inhaled anesthetics, or I could do intravenous anesthesia, and in some cases both of them are clinically appropriate, but which one's better? I don't know, right? So trying to address questions that the community has and is raising and is struggling with, I think that's a good strategy, because then you find your audience, and people want to have that information so they can make decisions that improve the situation. And that kind of leads to the third piece of advice I'd have, which is try to disseminate your findings. If you do a study like this, try to disseminate your findings to the audience where it makes the biggest difference. So I'm an engineer. I work in a university. I could publish my work in a highly academic engineering journal, but I don't do that because doctors aren't going to read that journal. Nurses and staff and procurement people, they're just not going to read that journal. So I always try to publish in places where clinicians and healthcare professionals, they go to for information. That's not always a journal. It could be website or a trade organization or government report. So finding the right outlet to maximize the change that you can make, and a way to find your audience, I think that's another really important thing to keep in mind for research.
Great. No, that's really valuable advice. I want to jump back. I think you had mentioned, and maybe I think I skipped around questions. You had some case studies that you were going to talk about from LMICs about where change has been really effective in this topic.
Yeah, thanks for the question. So one of my favorite studies in this space was done by a colleague at an ophthalmology clinic in India. And she worked with clinicians there and tried to understand the resources and GHG emissions associated with cataract surgery, which is a very, very common surgery. And they compared their findings in India versus a very similar, basically identical procedure in the UK. And they found a huge difference, And you might guess which way it was. The case in India was much, much less in terms of greenhouse gas emission. And they started looking into why. And so much of the reason was that the Indian clinicians and their whole kind of way they structured this particular surgery at this clinic was extremely efficient in terms of space, efficient in terms of time, efficient in terms of resources and supplies, like eye drops and, all the surgical equipment. And actually, they also found that the outcomes of the surgery were in fact better at the Indian facility, which was obviously that's the important outcome that we should all care about. So I really like this example because it it shows the importance of innovation, that in many cases in low and middle income countries, there's some more serious constraints in terms of economic resources or just kind of space resources for providing healthcare. And that has forced healthcare providers to be inventive and to really do the most they can with the resources they have. And in particular, to try to take waste out of the system. You can't afford to have waste, right, if you don't have a lot of resources in the first place. So actually, I think that settings such as where I am here in Boston, big center for healthcare provision in the United States, we have a lot to learn from these kinds of highly efficient practices and low carbon practices that have been innovated in other parts of the world.
Great. No, that's, I think, definitely kind of exciting, because I think there is, as you said, perhaps advantages to being in an LMIC, both in the fact that there are limited resources, which generally is, not a more negative thing, but you have to be more innovative. And also, I think there is more opportunity to build healthcare system with this as a mitigation strategies as like a key point from the outset, instead of having to work backwards and re-change systems, which perhaps in the US or other high-income countries is now what we're looking at. Yeah. My last question, I know you've already kind of given 3 really great pieces of advice. Do you have any other kind of general or recommendations for researchers in LMICs? Any kind of general last thoughts or advice?
Well, there's some great groups working all around the world in this topic. Of course, every country is different and every facility is different within countries, but I think there's a lot we can learn from each other. And so I, in addition to finding great collaborators locally, I would say reach out to others working in the space. For example, there's in certain situations, facilities that really need diesel backup power in order to survive, because the general grid electricity goes out frequently. And that's a certain kind of case, and there are different strategies for trying to decarbonize that type of energy than you would have in a place that doesn't have that kind of electricity reliability concern. So I would say network as much as you can. There's more and more, this is a hot topic in healthcare industry, or the healthcare sector, I should say. And so lots of countries around the world are developing case studies and guides, mostly for their own systems, but a lot of that can be shared outside of those countries as well. So take advantage of all the momentum here and plug in with your neighbors and learn together.
Great. Okay. No, thank you so much for taking the time to share all of that. So I hope you have enjoyed my conversation today with Professor Eckelman. This is a really complex and new area of research, and we are really grateful to experts such as Professor Eckelman for sharing their expertise with us. We would also love to hear your thoughts on this topic and conversation, so make sure to put your comments below. Don't forget to click like, share, and subscribe to our channel, HITAP_Thailand, for more insightful discussions, and make sure to tune in to our next episode. To know what other work HITAP does, visit www.hitap.net, or follow our Twitter, Facebook, and YouTube at HITAP_Thailand. You have been listening to the Post-COVID-19 podcast series brought to you by HITAP.